understand the drawbacks of sulfonylurea use in the management of type 2 diabetes mellitus. Speaking of the benefits, sulfonylureas are the oldest class of oral antidiabetic drugs dating back to 1950s. So the physicians have a long clinical experience with these drugs. Also, these drugs are cheap, inexpensive, and as we know that diabetes is a chronic condition and needs long-term treatment. So because of the low cost, the physicians prefer sulfonylureas in the treatment of type 2 diabetes mellitus. In terms of therapeutic efficacy, sulfonylureas are known to reduce the blood glucose level by 10 to 20% and glycosylated hemoglobin by 1 to 2%. So the effect of glycosylated hemoglobin is comparable, it is similar to that of metformin. If you look at the generations of sulfonylureas, they are divided into first generation and second generation sulfonylureas. Chlorpropamide is a first generation sulfonylureas, and some of the examples of second generation sulfonylureas are glyclazide, glimepiride, glipizide. The second generation sulfonylureas are approximately 100 times more potent than the first generation sulfonylureas. Although the T-half of these drugs is 3 to 5 hours, the duration of action of these drugs is about 24 hours. So single daily dosing is appropriate for most of these drugs. So in terms of benefits, because of the low cost, large clinical experience and good therapeutic efficacy, sulfonylureas continues to be used in combination with metformin in the management of type 2 diabetes mellitus. So now coming to the risk associated with sulfonylurea use in type 2 diabetes mellitus. Hypoglycemia is a major adverse effect of sulfonylurea which is profound and prolonged. The patient can experience severe hypoglycemia which may progress to unconsciousness and coma requiring hospitalization. So why is hypoglycemia more common with sulfonylurea compared to other oral antidiabetic drugs? As we know that in a non-diabetic individual, in a healthy individual, in the postprandial state when the blood glucose concentration rises, glucose is freely transported into the pancreatic beta cells and increased intracellular glucose stimulates the release of insulin, and insulin in turn promotes utilization of blood glucose by various tissues and organs, and this helps to lower the blood glucose level and maintain normal blood glucose. When sulfonylureas are introduced into a diabetic individual, they bind to the sulfonylurea receptors that are expressed on the pancreatic beta cell membrane. This in turn stimulates the release of insulin from the pancreatic beta cells into the circulation. To be noted that the action of sulfonylurea is independent of the plasma glucose level. It is independent of the concentration of glucose in the circulation, because even if the plasma glucose level is towards the lower side of the normal range, sulfonylurea will act to produce insulin secretion, and this will cause further lowering of the blood glucose level leading to a hypoglycemic episode. So the action of sulfonylureas is independent of the blood glucose concentration, and this is the reason why hypoglycemia is more common with sulfonylureas compared to the other oral antidiabetic drugs. To know more about the mechanism of action of sulfonylureas, these drugs bind to the sulfonylurea receptors expressed on the pancreatic beta cell membrane. This in turn inhibits or blocks the ATP-sensitive potassium channels, decreasing the efflux of potassium, causing depolarization of the beta cell membrane. This in turn opens the calcium channels, allowing the entry of calcium and increasing the intracellular calcium concentration. With an increase in the intracellular calcium concentration, there is stimulation of insulin secretion by the pancreatic beta cells to the exterior. So in this way, sulfonylureas act through the sulfonylurea receptors and produce insulin secretion, which in turn produces insulin action. Also to be noted that the risk of hypoglycemia is lesser with second generation sulfonylureas compared to first generation sulfonylureas. Generally, these drugs are avoided in elderly patients and in patients with liver and kidney disease because most of these drugs are metabolized and excreted by the kidney. So in liver and kidney dysfunction, these drugs and metabolites get accumulated in the circulation, and this can lead to enhanced hypoglycemic effect and hypoglycemic episodes. Hence, these drugs are avoided in these conditions. Also, patients with good glycemic control and with modest elevation of glycosylated hemoglobin experience hypoglycemic episodes. Therefore, it is important to start sulfonylurea at a low dose and titrate it gradually upwards based on the glycemic control. Self-monitoring of the blood glucose level is useful, and also the patient should be advised to take oral glucose on experienced symptoms of hypoglycemia such as hunger, restlessness, confusion, palpitation, and so on. So in this way, sulfonylureas act as oral anti-diabetic drugs by causing insulin secretion by the pancreatic beta cells. The second drawback of sulfonylureas is decreased therapeutic effectiveness on long-term use. It has been observed that patients with previous higher dosages of sulfonylureas or long treatment with sulfonylureas display gradual worsening of response on long-term use. This is because chronic administration of sulfonylureas cause continuous stimulation of the sulfonylurea receptors on the beta cell membrane, causing down-regulation of the receptors. The number of receptors on the beta cell membrane decreases. So this causes progressive dysfunction of the pancreatic beta cell, leading to worsening of insulin secretion. Also, there is decreased therapeutic effectiveness because of exhaustion of the pancreatic beta cells. The clinical result of this phenomenon is known as secondary failure, and this occurs because of exhaustion of pancreatic beta cells. So despite better glycemic control in the short term, there is worsening of the diabetes in long term. The third disadvantage of sulfonylurea is weight gain. Sulfonylureas enhance insulin secretion by the pancreatic beta cells and increase the plasma insulin concentration. So because of sustained plasma insulin concentration, there is weight gain, and as we know that one of the metabolic effects of insulin is lipogenesis, and because of the property of lipogenesis, weight gain is a common side effect of sulfonylureas. The American Diabetes Association guidelines recommend weight consideration during selection of an oral anti-diabetic drug. So sulfonylureas are generally considered in diabetic patients who are lean individuals or who are not overweight, and also in individuals in whom metformin is contraindicated or is not enough to achieve adequate glycemic control. So metformin is the first choice drug in the treatment of diabetes, and sulfonylurea is usually used in combination with metformin in the management of type 2 diabetes mellitus. The fourth important risk associated with sulfonylurea is increased risk of cardiovascular events. Several observation studies have shown that patients treated with sulfonylureas have increased risk of cardiovascular events compared to patients treated with metformin. To be noted that the second generation sulfonylureas have better cardiovascular safety profile compared to first generation sulfonylureas. The two second generation sulfonylureas that have proven cardiovascular safety is glyclazide and glimepiride. So glyclazide and glimepiride are considered to be cardiovascular safe drugs. Lastly, the other uncommon adverse effects of sulfonylureas are nausea, dizziness, rashes, blood dyscrasias. Hepatitis and cholestatic jaundice can also be a possibility. Water retention is a common side effect of chlorpropamide, which is the first generation sulfonylurea. So water retention occurs because of inappropriate secretion of antidiuretic hormone, which has water conservation property. It retains water and this causes water retention. Also, it has been seen that chlorpropamide, when administered along with alcohol, the patient experiences symptoms of headache, flushing, palpitation, and this type of reaction is known as disulfiram reaction. So disulfiram reaction occurs because of inhibition of metabolism of acetaldehyde because of accumulation of acetaldehyde. As we know that alcohol is metabolized in the liver to acetaldehyde, which is in turn converted to non-toxic acetic acid and is eliminated. So inhibition of metabolism of acetaldehyde to acetic acid leads to accumulation of acetaldehyde in the circulation, and this can cause toxic, unbearable, unpleasant symptoms of disulfiram-like reaction, and this is common with chlorpropamide, which is the first generation sulfonylurea. So to conclude, sulfonylureas are associated with several risk factors, the common ones being hypoglycemia, increased risk of cardiovascular events, increased risk of weight gain, and there are other side effects. So despite these risk factors, sulfonylureas continues to be a vital therapeutic category of oral anti-diabetic medications and continues to be used in diabetic patients in combination with metformin in the management of type 2 diabetes mellitus. Physicians consider modern sulfonylureas or second generation sulfonylureas such as glyclazide, glimepiride as smart and safe choices for the management of type 2 diabetes mellitus. So thank you for watching. If you find this video useful, please like and subscribe to this channel.